Okay, this is just an overview. It's our take on the new guidance that's been produced by the Department of Health, which is entitled Positive and Proactive Care, Reducing the Need for Restrictive Interventions. Now, item 58 says, under the heading of the safe and ethical use of all forms of restrictive interventions, that the legal and ethical basis for organisations to allow their staff to use restrictive interventions as a last resort is founded on 8 overarching principles. And these are the 8 principles. 1. Restrictive interventions should never be used to punish or for the sole intention of inflicting pain, suffering or humiliation. And I think we can all agree on that. 2. There must be a real possibility of harm to the person or to staff, the public or others if no action is undertaken. 3. The nature of techniques used to restrict must be proportionate to the risk of harm and the seriousness of that harm. So there in point 3 we have the common law right to use force in relation to reasonableness because it must be necessary and proportionate. Any action taken to restrict a person's freedom of movement must be the least restrictive option that will meet the need. 5. Any restriction should be imposed for no longer than absolutely necessary. And the point to bear in mind with item 5 is absolutely necessary is a human rights standard, and we'll come on to that in other presentations later. 6. What is done to people, why, and with what consequences must be subject to audit and monitoring and must be open and transparent. 7. Restrictive interventions should only ever be used as a last resort. And 8. People who use services, carers and advocate involvement is essential when reviewing plans for restrictive interventions. So it's talking about total transparency here, things like advance statements where you'd involve the family, etc. The key thing with these 8 overarching principles for me is item 2, which says there must be a real possibility of harm to the person or to staff, the public or others, if no action is undertaken. So what that means clearly to me is that if we don't do something, we're probably breaching the duty of care owed to someone and therefore we are liable for negligence. Point 3 is important because it reinforces the right of all staff to use force that's reasonable in the circumstances as dictated by our common and criminal law. But point 1 is interesting because it states that restrictive interventions should never be used to punish or for the sole intention of inflicting pain, suffering or humiliation. And I think the issue of pain there, especially when considering points 2 or 3, must be taken within the context of pain used for the intention of suffering or humiliation. In other words, when it's not necessary. Now, physical restraint in this document is referred to as any direct physical contact where the intervener's intention is to prevent, restrict or subdue movement of the body or part of the body of another person. So that's the definition of physical restraint within that Department of Health document. It goes on to say in item 69 that staff must not cause deliberate pain to a person in an attempt to force compliance with their instructions. Now that would seem to contradict the 8 overarching principles, but it doesn't, because it's talking about using pain merely to actually make someone do what you want them to do, and we can't use pain or force for that purpose. Where there is an immediate risk to life, in accordance with NICE guidelines, recognised techniques that cause pain as a stimulus may be used as an intervention to mitigate that risk, and we'll look at NICE guidelines in a second. So what it's saying here, just to bring it into context, is we should not use any technique that's going to cause deliberate pain purely to make someone comply with our instructions. But of course, under the broader aspect of reasonable force, as provided by common and statute law, we can use pain if it is proportionate to prevent a greater harm, and that's what they're validating here, where they're talking to actually use that to mitigate a risk in line with NICE guidelines. These techniques must be used proportionately, and we've just seen that in the 8 overarching principles, so I'm happy with that, and only in the most exceptional circumstances, and never for longer than is necessary to mitigate that immediate risk to life. And that falls within the broader concept of reasonable force. And these techniques should only be used by trained staff having due regard for the safety and dignity of patients. The use of these techniques must be embedded in local policies. And that's important because that references and validates the need for staff to be trained under health and safety legislation. Now, NICE guidelines, I said I'd come on to this because you just heard NICE guidelines referenced in relation to the use of pain. The guidance says that pain compliance is a method of physical intervention that employs skills and techniques such as thumb locks, which deliberately involve inducing pain. These techniques are only permitted in exceptional circumstances, so once again the word exceptional is used, as part of the short-term management of disturbed violent behaviour. They are only used once other methods have been tried and proved unsuccessful and must be proportionate, reasonable and justifiable response to a situation. Now, just to clarify that last paragraph, this doesn't necessarily mean that you have to go through a whole range of techniques first and then use pain if it's needed, because that would have complications in terms of people fatiguing, the ability for people to actually do stuff under pressure and distress. What it does mean, however, if we refer to human rights legislation, is that there must be an evidence audit trail that other options have been looked at and actually tried and tested or at least evaluated, and then if they are not going to work, it becomes absolutely necessary, and they're the human rights keywords, absolutely necessary to use a technique that may cause pain, provided, of course, that it mitigates a greater risk. Going back to the document on positive and proactive care, item 70 says that people must not be deliberately restrained in a way that impacts on their airway, breathing or circulation. Very, very important when we're considering the risk of position asphyxiation. The mouth and or nose must never be covered, and techniques should not incur pressure to the neck region, rib cage and or abdomen. And we've seen this before highlighted in various documents that go way back to 2010, where techniques, for example, such as basket holds, double basket holds, seated double embraces, those sort of things should not be used because of the risk of position asphyxiation. And there must be no planned or intentional restraint of a person in a prone, face-down position or on any surface, not just the floor. And that's quite an interesting inclusion, because what it's saying here is that we should not intentionally take people into a prone, face-down position, not just on the floor, but on any surface. So it's eliminating the need to use prone. However, this must be read consistent with the 8 overarching principles that talk about the use of force being necessary and proportionate. And this document, as we'll come on to later on, also talks about mechanical restraint. And unfortunately, one of the positions that you would need to use if you had to apply handcuffs to someone in a highly volatile and toxic situation would be when the person is in a face-down position on the floor, because that's the only position that you could credibly apply those handcuffs on to make sure that they actually went on properly. So we need to look at this holistically, we need to look at this in a mature way, and we need to look at this in relation to the broader sense of using force as well, because at the end of the day, this is only a guidance document. If exceptionally a person is restrained unintentionally in a prone face-down position, staff should either release their holds or reposition into a safer alternative as soon as possible. And I would agree with that. And we already have contingencies in our training programs where if a person throws themselves to the floor, staff will disengage. This is very, very important when we're looking at other issues such as attachment issue. And that's been proved to work extremely, extremely well. And obviously we have modified recovery positions, seated positions, the use of other aids as well, such as bean bags, which eliminate the need to actually put someone into a prone position and hold them there. Staff must not deliberately use techniques where a person is allowed to fall unsupported, other than where there is a need to escape from a life-threatening situation. Now, in terms of restraint, if we are holding someone, and this happens a lot with children and some adults, they may raise their feet and swing and let their body weight take them to the floor. And what this is saying is we shouldn't allow them to fall unsupported, but we also have to look at this guidance consistent with health and safety legislation, and particularly the manual handling regulations, which say that if a load becomes unstable, we should put it down. And that's something really important that we need to consider. Going back to the Joint Committee on Human Rights, it talks about this in a report that came out in 2003-2004, where it says the restraint in a prone position has been particularly controversial because of the dangers it carries to the patient, and it has been implicated in a number of deaths. So the Joint Committee on Human Rights from the House of Lords and House of Commons is validating the issue here, that prone restraint is a life-threatening issue. And therefore, it goes on to say, actually, that reliance on the prone restraint is a matter of concern for compliance with Article 2, given the known danger of this position evidenced by previous deaths. So, if we read the guidance document consistent with this type of report, we can see that we do not want to be taking people down forcibly as a primary method of intervention into a prone type position, because there are implications there if someone dies from a human rights perspective. It also goes on to say that staff must not use physical restraint or breakaway techniques that involve the use of pain, so we're back to this issue once more, including holds where movement by the individual induces pain other than for the purpose of an immediate rescue in a life-threatening situation. So just to look at this in terms of what it says we should not use any technique for restraint or breakaway that involve the use of pain. So we should intentionally use pain. But it goes on to say that even where the person we are restraining moves, so they move and they induce the pain, we can't use that either. Now, I have to be clear on this. I don't think there is any technique out there that is 100% risk-free, because any intervention, because of the various dynamics involved and the uncertainties involved in a dynamic situation, is going to have the potential for pain and harm to be caused. And therefore, I think this statement is slightly naive and slightly unworkable, particularly when we read it in light of the 8 overarching principles, because it doesn't seem to sit with these 8 principles, particularly item 3, where it says the nature of techniques used to restrict must be proportionate to the risk of harm and the seriousness of that harm. And one thing here, when we look at the need to eliminate the use of prone restraint, so we've got someone who's going to throw themselves to the floor and there's a risk of restraining on the floor, possibly, and again, this is just my opinion on this, and it needs to be looked at in a whole broader scope of every situation on an individual case basis. My opinion is that if the use of a technique that is more restrictive, say for example a wrist lock, can prevent someone from actually throwing themselves to the floor, and therefore we can maintain them in a standing up position, we can eliminate the need for movement, we have staff that are less tired and fatigued, we have a service user who's not going to be as tired and fatigued, and we're going to have the ability to prevent someone going to the floor and therefore eliminating the need for prone. Also, we have an increasingly aging population in many areas of work, and we have staff now who are getting older, who are expected to restrain people who are younger than them, maybe fitter, more powerful than them, and carrying less injuries. And if we eliminate the need for any technique which either intentionally induces pain or induces pain by the movement of the service user or patient or third party, then that omission, that negligent omission, if it leads to a serious injury, harm, or God forbid death, is something that needs to be seriously looked at and considered in the overall planning of this, particularly when we go back to the aspects of human rights legislation which talks about absolutely necessary and the need for actually to be proactive and taking positive proactive steps to eliminate the risk of death where a known risk to death exists. So in summary, I think the guidance is good. I think there are a lot of good things in there. I think there are some conflicting issues in this in terms of how this will be read. I think there will be problems in terms of inspectors in subjectively interpreting this if it's not looked at holistically within the broader context of other legislation, particularly common law, criminal law, human rights legislation and health and safety legislation, and also in consideration of the social makeup demographic of staff and service user when considering the psychology and physiology of people who are going to be involved in physical restraint incidents.